I think we had transformative results in 2023 in the metastatic bladder cancer space with enfortumab vedotin and pembrolizumab. It really changed the landscape of metastatic urothelial cell carcinoma. It doubled the overall survival. You have 30% of them who had a complete response, and even a lot of these responders are ongoing after 2 years. 75% is still in a complete remission if they achieved it. So we entered these products into the muscle-invasive bladder cancer space. And we choose for the KEYNOTE-905 the very bad population, the frail population, a lot of comorbidities. This is ineligible population. Most of them are cis-ineligible based on renal impairment. They can also be based on eco-performance status, can be based on cardiovascular disease, it can be based on polyneuropathy, hearing impairment. But we chose this population. We omitted for peripheral neuropathy because enfortumab vedotin is also giving this. Because these patients don't have any options. They go with muscle-invasive bladder cancer, they go straight to surgery, upfront surgery, and then they're followed up. But there are not that good data of what is the prognosis of this patient population, but we know that it's very bad, that up to 70% of them will relapse, and most of them, a lot of them will die within 5 years. So this is the population setting, and we had the control arm in the MIBC cis-eligible population, and then we added 2 experimental arms, the pembrolizumab monotherapy arm and the EVP experimental arm, perioperative, so 1 year of pembrolizumab and 3 cycles of EV in the neoadjuvant setting and 6 cycles in the adjuvant setting. And all the patients with MIBC cis-ineligible could enter the trial. And in 2022, based on these promising results in metastatic setting, we stopped the pembro monotherapy arm and we continued only with the EVP versus the control arm. And what we presented here at the Congress is the first pre-specified interim analysis of all patients concurrently randomized to the EVP arm versus the control. And the centrally assessed event-free survival was the primary endpoint, and key secondary endpoints is overall survival and pCR. And it was a very strong hit for all of them. So the primary endpoint of event-free survival showed the early and a sustained separation of the Kaplan-Meier curves, translated in a hazard ratio of 0.4 in favor of the EVP arm. And then you always want to be that translated into an overall survival benefit, and we also had that hit also with a hazard ratio of 0.5, which was quite good. And at 2 years, for example, you have 63% of patients that's still alive in the control arm and up to 80% in the intervention arm. And also very important is the endpoint of pCR, also a key secondary endpoint. We were very fair in that we used the denominator of all the ITT populations. So even the patients that have an extremely good clinical response on enfortumab vedotin, pembrolizumab, but opted not to go to surgery, were also considered non-responders, because for the denominator we used also all the patients that did not go to surgery. And for the pCR, by this analysis we ended up with 57.1%. So you can imagine if you add this good response, it will be even higher. But this is already the highest pCR rate ever reported in a phase 3 MIBC trial. And maybe that also paves the way for the next gen trials with bladder sparing, because you can imagine if you tell to your patient, we remove your bladder, but we see APT 0 and 0, that the patient will question you, but why did you remove it? So I think this is, first of all, a trial that is transformative for the MIBC patients who are cis-ineligible. And I hope that it will be confirmed in the cis-eligible patients with P15 trial that's still ongoing. But for now, I think I will be very happy to offer this to all of my cis-ineligible MIBC patients. And it also paves the way for a lot of beautiful trials to come, I think.